So, evening, all the aspirants present here. Today's topic is trauma and burn, and the faculty that we have here is Dr. Arun Raja Thangavel. Sir, over to you. Thank you.
Hi everyone. Sorry for the delay in setting up the IT. IT always causes some delay. It's universal. As Fatma introduced me, I'm Arun. I work currently in UK as a senior clinical fellow. So I passed my EDIC exam in 2024. I took a course with Farz Academy. I found it hugely helpful, and now I've joined as a faculty in teaching. So this is for the crash course I prepared, but never forget to believe in yourself. That's what will carry you towards the success. Few ground rules. My classes are going to be very interactive. I depend on you guys to come up with the answers and take it from there to maximize your benefits by treating it like a mock exam. Uh, can you see my slides and hear me well? Just say something in the comment or unmute yourself so that I know I'm audible. Neil, yeah, great. Thanks, Raj. Yeah, I don't want to waste time in the introductions. If you can introduce yourself briefly in the comment section, that will be usually helpful so that we can interact better. So please keep videos on if possible. I know some of you might be working, so that's absolutely fine. And we'll take it from there. So how this is going to work is I want you guys to type in the chat your options. So then we can see and discuss the questions. If that's okay. Yeah. Just type in briefly what you do as well, whether you are in training or a consultant or what level of depth experience you have. So that will be helpful. And also we can wait for a few more people to join. I know it was a last minute change in link, so some of them might be still connecting. So you are Arun as well. Arun Rana, thanks for joining. So yeah, go ahead, type your answers. If you can see my screen. 35-year-old male following a high-speed motor vehicle collision is transferred to the trauma center. His audio is unclear. Let me increase volume. Is that better? Great. Yeah, thank you. So he's intubated and has a stable pelvic binder in place. Fast is negative. Oops. Fast scan is positive. His blood pressure is 85/40. Heart rate is 135. Is cold, clammy. After 2 liters of crystalloid and ongoing blood transfusion, there is no improvement. What is the most appropriate next step in management? So type in your answers. Yeah. Raj says A. So I want all of you to respond if possible. Or if you want to unmute and talk, you can do that as well. Then we can discuss the answer. Okay. So a few of you are sent D, Rebova, we'll discuss that. Yeah. Good. So this is an interesting question. Like all the options seem like they are not wrong, but the answer is most appropriate. Rebova, that's an interesting topic of research currently. There is some evidence coming up that in pelvic, like uncontrolled pelvic bleeding like this, Rebova can be quite useful. But the problem there with Rebova is still we are doing a lot of trials. There is no clear consensus, and yes, yeah. If you have any questions, please stop me there and ask. We can discuss more about that. Yeah. So with the ADLS, there is no clear consensus guidelines on Rebova, so I wouldn't choose that, even though the evidence is still upcoming. Here, the best option seems to be the urgent angioembolization by interventional radiology, especially with known pelvic bleeding. So they wouldn't go and do exploratory laparotomy for these cases. And nowadays, more and more, we are shifting towards interventional radiology. so that will be the answer of choice. For those who answered albumin, so albumin, um, not a, it's not like a wrong answer, but I think more definitive management here is controlling the bleeding. So I would go with C. And yeah, this is the Reboa technique for those who don't know. So basically, it's like a Foley's catheter. We pass it down the femoral artery and place it in the aorta and inflate the balloon so that below the level of aorta, if there is any bleeding from where the balloon is inflated, it can be controlled. As it's only a temporizing measure and it causes perfusion problems in the lower limb, it's only for a short duration for like few minutes before we can do any definitive control. So it's being trialed in UK as well as Reboa trial. Those who are doing air transfers to the trauma centers, if the patient is having uncompressible bleeding below the level of like abdominal aorta, then they are doing this. And it's currently under trial, so there is no clear evidence. So we will have to wait for few years. Maybe it's a good opportunity, like good option in the future for the same question, but currently I'll choose C. Yeah. Okay, moving on. Which trauma scoring system does not require knowledge of anatomical injury and predicts mortality accurately? I know it's more of a reading in between the lines question. Give it a go. Is it abbreviated injury score, injury severity scale, revised trauma score, emergency trauma score, or stress model? Okay, it's a bit scattered. Fine. So this question I have taken from the modules available for from the European Society of Intensive Care. So if you have become a member of European Society ESICM, you get the access to the EDIC modules. So those are really important for the exams. Some questions can come directly from those modules. So I would strongly advise you go through those modules. And it's a quite good material to read as well otherwise. So for this question, the answer is D, actually. So if you look at the question, so abbreviated injury scores definitely needs anatomical knowledge. So it's based on which region you give like score of 0 to 6 based on the severity of the injury. And injury severity scale is basically you just square the top three abbreviated injury score of the 6 systems. So maximum score you can get up to 75. This 0 to 6, 6 is the severest end of the spectrum. It's not life sustaining. So maximum score for the ISS will be like 5 in each, and you can model. So the stress model is a mathematical model. It predicts mortality very accurately, but it needs anatomical knowledge again. It kind of combines ABC, abbreviated injury score, ISS, and revised trauma score. So the most appropriate answer here is emergency trauma score. It's all like you have to read it and memorize it, otherwise